I'm Dr. Rohit Shetty. I head the refractive unit and also the chairman of Narayana Nethralaya Eye Hospital in Bangalore, south of India. I've been using the biomechanics, the pentacam for the last close to 2 decades now. See, when we started looking at biomechanics, it looked like a great thought in theory, but very little application in practical. But close to a decade now or more of using biomechanics and the topography link, our understanding started becoming more mature. And at this point of time, it forms a very integral part of my planning of refractive surgery, because we do all type of refractive surgery. Now, with the newer generation lenticule-based procedures, and where you're trying to adjust your energy, the spot size, and you're doing multiple things, which we never did with the previous machines, I feel the integration of biomechanics becomes more and more relevant. And I feel that if you understand the biomechanics, if you put an effort to make that understanding properly, then you will connect to it much better than being very superficial. See, one challenge we always had is when we are very superficial with understanding of biomechanics, we discredit what it's actually doing because we have not understood what it's actually giving you back. So I request the clinicians to spend a lot of effort and time initially to understand it everywhere, everything about it. And then I think it becomes a fantastic tool in your clinical practice. The biomechanics has 3 important foundations in my clinical practice. One, to choose yes or no. Should I do a surgery or should I avoid completely? So this is a very important thing today, because clinicians are still having a lot of lacunae where you can't decide whether you have to do a procedure or not. The point 2, which is the second foundation, if I choose to go yes, what type of technology I use? I use a PRK, I use a smile extra, or I use some other lenticule procedures, or I just decide to do ICL. So that is the second foundation. The third foundation is when you're looking at a case where you've said no to a particular procedure, maybe 3 years back or maybe long in the past, and these patients come to you and ask, oh, can you do something about it? Now, based on topography, you're still not sure, but the biomechanics will try to tell you, oh, you may not be suitable for LASIK 5 or 7 years back, but now you may be suitable for PRK or extra procedures with lenticule-based surgeries or an ICL. So it is, and these 3 foundations are happening at a very regular time, all time in our practice, in my practice, and which I teach to my residents, my fellows, the people who come to me to learn, is to use these 3 things to connect. The biggest worry is that when you integrate biomechanics, your practice will reduce, because you are not rejecting anybody, you're just triaging them. So we have to understand that the biomechanics is not to reject, but to triage to what kind of procedure you want to do. In fact, my refractive procedures, I can directly credit, it has gone up by around 25 to 28% year on year. Just because I'm integrating this, I'm going to triage my patients. And where I feel it can be used more is, which I'm trying to do, is to connect to the I use, we're one of the few hospitals in the world to use all the lenticule-based procedures, ATOS, the Elita, Silk, Smile. These are 3 main ones. And we are trying to see if I can use biomechanics to integrate into way I set my energy, spot size, track distance. And these things probably will open up a completely new box of use of biomechanical parameters. And if you are using it for right way, biomechanics is just used for one of the foundation. Yes or no. But if you use it for all the three foundation I said, then you will increase by close to 28 to 30%. There is no way you will reduce your practice. In fact, it's an opposite, actually spend less time. If I have a doubt in a topography, I would spend a lot of time thinking, debating. All the demons in your mind will try to tell you not to do it. All your other aspects, all your positive, as angels will tell you, say that you can try this, you can try that. But the question is, what really guides you? Nothing. So if I have this parameter in my file with the patient, then I exactly know that I have already decided based on it before the patient comes in, because my triaging is done. So in fact, I spend less time and I tell my patient, this is what I'm going to do, because I have done your strength of your eyes, measurement which looks at the strength of your cornea. And I figured out that this strength will need this kind of procedure, and the patient is convinced. The patient is convinced, I am convinced, and it's faster. Actually, the workflow is much faster than sitting and thinking about what I can do when I don't have anything else other than the topography. Absolutely. And they all measure it. And we do us is a very high-end optical and molecular research center. So I have compared a lot of this biomechanics data with, we are one of the only hospitals to have a polarization sensitive OCT, which measures the collagen structure. And we have been correlating the collagen structure using the biomechanics, and we are very close. That means what the collagen structure says, the biomechanics is telling the same thing. So that means it's proof that it is not telling something which is completely not true. Biomechanics is not a mathematical game. It has a very strong proof that it can be used to triage, to consult, to motivate surgeons to do refractive surgery safely. What's important is, instead of learning very superficially, just a few parameters here and there, I feel we should invest more on teaching of biomechanics in a very, very scientific way. So I would encourage the surgeons to put their efforts. Once you understand it, once you learn it, then you are going to increase your business. No doubt about it. And I would request them to integrate it as fast as possible if you're not done it already.